call for action. We need to address challenges now, the South African experience, and it's my pleasure to introduce Professor Wendy Spearman, who's head of Division of Hepatology, Department of Medicine, Faculty of Science at the University of Cape Town. She's also head of liver and liver transplant clinics at Groote Schuur Hospital. And of course, she's leading the ECHO project in Sub-Saharan Africa for training and awareness among physicians in Sub-Saharan Africa.
Thanks very much, Minal. So I'm going to be looking at the challenges that we face and a little bit of how we're going to address that. So I think if we're going to really address viral hepatitis, we need to understand the epidemiology and the burden of disease within our regions. It's important that we know the overall seroprevalence and potential high-risk groups, and obviously implement effective prevention strategies. But this is going to require us to identify infected individuals with affordable access to diagnostics, linked to care, and that requires us to overcome the lack of access to physicians, gastroenterologists, hepatologists, but importantly also overcome stigma, discrimination, and criminalization that many of our marginalized key populations face. And importantly, we're going to have sustainable access to antiviral therapies, with simplified treatment algorithms which have appropriate indicators for initiation of therapy within Africa. And also recognize we have a number of unusual hepatitis C genotypes in Africa that need to be addressed. But ultimately, we're going to need a coordinated public health approach. So we all know this graph very well, looking at the global targets for 90% reduction in new infections and a 65% reduction in deaths by 2030. But in reality, we're in 2022, and we're towards the end of 2022. And so if we are going to really address this, I think, particularly in WHO Africa, where we face many of the challenges, we haven't met many of the targets, we need to look at implementing interim and 2025 targets to bring us up to speed and also to ensure that we reach the 2030 targets. So the global epidemiology, you very well know, 296 million with chronic hepatitis B, with Africa and Western Pacific accounting for 67% of those actually infected. Of the 58 million living with chronic hepatitis C, we've had a high burden of Egypt, but this has been well addressed, Nigeria and many other countries in Sub-Saharan Africa. And 38 million are living with HIV, of whom 67% reside in Sub-Saharan Africa. And in terms of co-infections, we know there's estimated 2.7 million of HIV hepatitis B co-infections, with once again 73% living in Africa. In terms of HIV co-infections, 2.3 million. And it's really important to identify these co-infections because they often have a much more aggressive course of disease. So if we look at surface antigen positivity, we know that in Sub-Saharan Africa, 82 million are infected, between a 7.5 to 8% prevalence, and for viremic hepatitis C, about 9 million or 0.84 prevalence. But important, the burden of disease, in 2019, estimating almost 1 million new infections occurred, accounting for 67% of the global new infections, 80,000 deaths, or equating to almost 12 deaths per hour. For hepatitis C, 210,000 new infections, 45,000 deaths, or 4 deaths per hour. And although in 2018, 28 countries had national viral hepatitis strategic plans, many did not. And unfortunately, even in those with strategic plans, access to affordable diagnostics and testing remains limited. And then really the big problem of hepatitis B, how to bring down hepatitis B surface antigen positivity in children under the age of 5, and it's estimated we have almost 5 million in WHO Africa. And this really reflects the failure of maternal and child health services to prevent mother-to-child transmission, as well as early childhood horizontal transmission. So everyone is very well aware, from mothers to healthcare workers to community workers, about the risk of HIV acquired from mother to child. And so it was estimated about 190,000 per year. But what we don't really often think about is the number of hepatitis B infections that occur in infants yearly, almost double the number of HIV. And the studies from the Prolifica study in the Gambia showed if you acquire this from your mothers in early childhood, in fact, there's an increased risk of liver cancer. So we really need to address this problem. Globally, for hepatitis C, we now know that most new infections are in high-risk groups, so people who inject drugs or MSM. But in Sub-Saharan Africa, we see a bimodal age distribution. Many of our older patients acquired it iatrogenically from unsafe blood and blood product transfusions, also previous mass vaccination and parental treatment programs. And unfortunately, we still have ongoing unsafe medical practices, dental and surgical interventions. And then the role of reusing instruments in traditional practices such as scarification and circumcision. And increasingly now across our region, we're seeing increasing people who inject drugs who are facing stigma and criminalization in their attempts to get care. So just briefly going a little bit more into people who inject drugs. In the Sub-Saharan Africa, it's region is estimated there's nearly 1.4 million, but by 2030 there will be a 40% growth in these individuals. And so if we look at the prevalence, it's 18% for HIV, 3.7% for hepatitis B, and 21% for hepatitis C. So we really need to identify these individuals and link them to care appropriately. And once again, if we don't prevent hepatitis, viral hepatitis, if we don't identify those who are treated, who need treatment, and initiate treatment programs, and importantly, those who have advanced fibrosis and cirrhosis, initiate appropriate liver cancer screening programs, we are going to have an ongoing problem where HCC is the second leading cancer in men and third in women, and 10 African countries are actually amongst the 25 countries with the highest age standardized rates per 100,000, with Egypt at 34.1 and the Gambia at 30. And unfortunately, liver cancer here affects young individuals, median age only 45. And if we look at the median survival, it's really only 2.5 months compared to 11 months in Egypt. And this really reflects that 72% are presenting in stage D, which really only options are palliative therapy. So once again, we need to actually screen these patients and identify them and get them onto appropriate antiviral therapy. And this analysis really just shows how viral hepatitis is driving the burden of HCC in sub-Saharan Africa, with 65% due to hepatitis B, 27% for hepatitis C, and 15% for hepatitis D. So if we're going to look at elimination, we're really going to need to decentralize, break down silos of healthcare, and one's going to need testing and intervention at all stages of the continuum, from prevention to screening and linkage and treatment. So in terms of prevention for hepatitis B, vaccination is at the forefront. We need to implement this, but importantly, we need to look at other modalities to prevent mother-to-child transmission. So surface antigen screening of pregnant women is essential, the birth dose vaccine, and offering tenofovir to those who are highly viremic. Unfortunately, we still need to address blood safety, injection safety, and we really need to upscale our harm reduction services. So in terms of the birth dose vaccine, as we've heard, only 14 countries have actually introduced this, and only 7% have timely administration. But importantly, even for universal hepatitis B vaccination, we're lagging behind at 71% coverage, where we should be aiming for 90%. Importantly, also the risk of chronic infection is nearly 4 times higher if the interval between that first and second dose is more than 10 weeks. So not only do we have to implement the birth dose vaccine and universal hepatitis B vaccine, but we need to follow the appropriate time schedules if we're going to be fully effective. So in terms of the birth dose vaccine, what have we achieved in terms of universal vaccination? What have we achieved in bringing down the prevalence amongst children under the age of 5? Unfortunately, for the WHO Afro region, although we had a less ambitious target of less than 2%, in fact, 2.5% prevalence still prevails, although globally we're now down to 0.94. And only 15 countries, or 32% of the region, have actually reached that goal of less than 1%. So this is an area that we really need to be working on. What are the challenges in terms of delivering that birth dose vaccine? Well, as we know, the monovalent vaccine is not funded by agencies like Gavi, although pre-COVID there were negotiations for the delivery of that, and that needs to be taken up again. And the problem is that the cost of the vaccine falls below the Gavi funding threshold. But even if we address that, we need to remember there are costs of infrastructure for vaccine delivery, and there are potential cultural factors that can reduce the access to healthcare in women in the postpartum period. But I think ultimately hepatitis B intervention is really considered a public health priority. Pregnant women are often having to pay out of pocket for surface antigen screening and for the birth dose vaccine. So I think if we look at how we're going to address this, we need to have really coordination between immunization and maternal health services. We need to potentially increase health staff attended births, but also expand the delivery of vaccines. So looking at pre-filled injection vaccines for home births at affordable prices. But I think we need to educate pregnant women on their right and the need for surface antigen screening and birth dose vaccine for their infants. But once again, also increase healthcare worker awareness of the need for that timely birth dose vaccine. And we can also simplify supply chains by using heat-sensitive labels to allow storage outside the cold chain. We know that this is now safe, but the monovalent vaccine will need to be licensed for this. But ultimately, these acceleration of efforts will require political engagement by governments, international funding agencies, with financial commitment and strategic planning to actually implement the birth dose vaccine. So looking at blood safety, unfortunately, this is still a problem. In 2018, only 77% of donations were from voluntary non-remunerated donors. And 5 countries reported being not able to test for all the transmittable infections, and 4 countries were not able to test all donations for hepatitis B or hepatitis C. But importantly, not only testing is important, but quality assurance. So the use of standardized operating procedures, participation in external quality assessment is essential. And in low-income countries, this is only reaching about 76%. So national hemovigilance systems, supported by local transfusion committees, will enable ongoing surveillance for transfusion-related complications. But once again, this requires infrastructure. In low-middle-income countries, only 28% are able to operate these hemovigilance systems. So in terms of unsafe healthcare injections, unfortunately, 3.7% are still unsafe in WHO Africa region. And this really relates to reusing needles and syringes, injection overuse, particularly with our vaccination, mass vaccination programs and parental treatment programs, and also the lack of access to reuse prevention devices, which are often costly. But we do need to educate healthcare workers in universal precautions and provide safe waste management systems. And if we look at this map, this is really dismal. We look at the provision of harm reduction services in Africa, and you can see very few countries are actually providing opiate substitution or needle syringe programs. And so if we look at the 2030 target to have 300 needle syringe sets for injecting drug user per year, we only have 6, so we're really falling well behind here. And one of the problems is this is often NGO funded rather than state funded, and that needs to change. So in terms of the hepatitis B cascade, we've heard this, only 2% have been diagnosed, 0.1% of those diagnosed treated, and for hepatitis C, similarly, only 5% diagnosed and less than 1% treated. But if we actually manage to diagnose and embark on treatment, we do need treatment guidelines that are actually tailored for Africa. And this is very well demonstrated by Ethiopia, where they looked at 1,000 patients with chronic hepatitis B, and they applied the APRI score of greater than 2 to detect cirrhosis. In fact, this failed to detect 50% of patients. And similarly, a much smaller study from Ethiopia showed that the FIB4 rule-in for cirrhosis of 3.25 had only a 55% sensitivity. And as a result of this, the HepSanet group grew out of one of the COLDA meetings, and this looked at more appropriate FibroScan cutoffs for hepatitis B, and showed that a more appropriate rule-in threshold for cirrhosis was 0.65, and a rule-out threshold for cirrhosis at 0.36. Another area that we often tend to underestimate is the presence of unusual hepatitis C subgenotypes. And this is very well demonstrated in Rwanda, where they looked at the shared studies, where for soft-ladiposphere, genotype 4R only had a 56% sustained viral response. Fortunately, retreatment with soft Valvox was effective at 98%, and the more recent shared 3 studies showed that soft Val gave a 97% SVR. So it's really important when we're deciding on what pan-genotypic regimens we're going to follow. And then similarly, the genotype 1, the study from a retrospective UK study that Jeff Dushek was involved in, really showed that there were novel genotype 1 subtypes, and their SVR rates were only 75%. So we need to be aware of these when we actually embark on treatment regimens. So if we're going to improve diagnosis and linkage to care, we really need to break down silos of healthcare management. We need to integrate delivery of care for HIV, TB, viral hepatitis, and non-communicable diseases, really recognizing the rising prevalence of obesity and diabetes, with MAFLD now becoming an important negative cofactor for those with viral hepatitis. So we need to decentralize, task shift to primary healthcare. We need easy treatment algorithms and guidance on referral pathways for complex cases. Rapid diagnostic tests and dried blood testing improves access to diagnosis, and particularly if we use reflex viral load testing in those who test positive on dried blood plus tests, that will increase our actual delivery of care. And then importantly, combination of rapid diagnostic tests for HIV, viral hepatitis will increase uptake and diagnosis and access to therapy. It's been very clearly shown that full decentralization of hepatitis C testing and treating increases uptake, linkage to care, and achieves comparable SVR rates. And so we need campaigns to test and treat. We need affordable access to pan-genotypic DAAs, which are appropriate to the genotypes that we find in our region. And importantly, we need to ensure access to Tenofovir and TAF for hepatitis B mono-infected individuals. But this integration will require dedicated funding for the infrastructure to combine all these services. So we all know about COVID-19 and the disruption of services, but I think we need to learn from this. There's been a rapid upscale of diagnostics, including PCR platforms. the use of community healthcare workers to trace patients and deliver vaccines, and we can overcome a shortage of specialised healthcare workers with telemedicine distance learning systems, smartphone treatment applications, and what we're trying to achieve with the Project Echo Viral Hepatitis clinics to improve delivery of best practice care to under-resourced regions. So ultimately, we're going to really need political will to recognise viral hepatitis as a public health priority, set national elimination targets, develop and implement national viral hepatitis plans, which do need dedicated funding, universal access to affordable diagnostics and therapeutics, and we need to integrate the healthcare services for communicable and non-communicable diseases. Thank you very much.